This talk is about flash and intraoperative visual evoked potentials in electroretinogram. It is intended for the clinical neurophysiology fellows at Nick Lau's Children's Hospital. It will be conducted in a question and answer format. The first question is, flash VEP only involves the retinal lateral geniculate occipital pathway. A, true. B, false. Flash VEPs are probably generated primarily by white ganglion cells activation. The axon of these ganglion cells end up in the pulvinar and lateral geniculate nuclei. Axons from neurons in the pulvinar nucleus travel to the parietal cortex. Axons from neurons in the lateral geniculate travel in the optic radiations to the occipital cortex. Neurons in the occipital cortex send axons to other occipital areas and to the parietal and inferior temporal cortices. So the answer to this question is B. Next question. Which of the following statements is not true regarding flash visual evoked potentials? A. Flash VEPs is less sensitive than pattern VEP. B. Best limited to patients with poor visual acuity. C. Best limited to oncooperative patients. D. Rarely contaminated by artifacts. Pattern VEPs are sensitive to ocular pathology. Flash VEPs are not sensitive to ocular pathology. This tracing is the result of a pattern VEP study in a patient with cataracts. No identifiable wave are present, whereas in the same patient the flash VEP was normal. A normal flash VEP suggests that correction of the cataract will greatly improve vision in this patient. So flash VEP is a study of choice in patients with poor visual acuity that cannot be corrected with glasses, in oncooperative children and oncooperative adults. Artifacts plague flash VEP are very frequent in these patients. The detection of pathology, here represented as a red dot, differ according to the VEP modality used. A small lesion, as the one I am representing in this figure, studied by flash VEP, is usually missed. Similar lesions studied by pattern VEP are usually detected. So the answer to this question is D. Next question. Qualitative flash VEP require Gangfeld stimulators. A, true. B, false. Flash visual evoked responses can yield quantitative information or qualitative information. Quantitative information can be obtained using Gangfeld stimulators or similar devices. They allowed patient observation to monitor attention and eye position. Qualitative VIP can also be obtained. They can be obtained using regular photostimulator lamps, matrix of light emitting diodes, or light emitting diode goggles. Quantitative flash VIP require patient cooperation. The patient should be attentive to the test being conducted and looking at the screen. Lamp stimulators make noise and may require the use of earphones with masking noise. Eyelids may be open or closed during the examination. Preferably, the direction of the eyes should be towards the lamp. Goggles are becoming the most frequently used equipment to perform flash VIP. Eyes are usually closed. So the answer to this question is A. Next question. Earphones with white noise are often required to perform flash VIP using A. Ganzfeld stimulator, B. Photostimulator lamps, C. Goggles, D. None of the above. I showed you this figure just a few seconds ago. I am showing it to you again to make sure that you remember that lamp stimulators produces noises, and the noise may produce artifacts. Hence, earphones with white noise are often needed when using lamp stimulator. So the answer to this question is B. Next question. Which of the following statements is not true regarding flash VIP? A. Lamp should be 30 centimeters away from the patient. B. Monocular testing is preferred. C. Goggles cannot be used for monocular testing. D. The light stimulus should last 5 milliseconds or less. Most of the time, flash VIP is done on one eye at a time. The eye not being tested should be covered with a device that prevents light from going through it. This should be so regardless of the stimulus method being used. Simultaneous bilateral stimulation can also be done, but it has little or no clinical purpose. Luminance should be 3 CD per square meter. I find it curious that the International Society of Ophthalmology also says that luminance should be 3 candelas per square meter or more, but adds per second and places a negative sign prior to the square, as you can see in the parentheses in this frame. Flash duration should be 5 milliseconds or less. The subtended visual field should be 20 degrees or more. The rate should be between 0.9 to 1.1 flash per second. The number of trials should be 64 to 100 per average, and there should be 2 average per tracing. When a lamp is used, it should be 30 to 45 centimeters away from the patient. Equipment should be calibrated. I have not been able to determine how often it should be calibrated. It certainly should be calibrated the first time it's brought into the lab, but thereafter I find no actual number to determine when it should be recalibrated again. My guess is it should be done every year, or any time that the room or any of the parameters used in the room of the testings are changed. So the answer to this question is C. Next question. There is worldwide agreement on the direction of polarity and labeling of the peaks found in flash VIP. A true, B false. This frame shows 6 flash VIP studies. I put them together so you can see how different they look from each other. Some of this variability is due to the stimulus method used to trigger the evoked potential, but others are just due to lab peculiarities. The labeling of peaks is also different in different labs. In this tracing, the term P100 is used for this given potential, as it is in this one. But notice the different numerical values in the labeling of the other peaks. In this one, the label used for the most prominent wave is P2. The P indicates positivity, but the peak is down. This one also uses P2, but here the peak is up. In this one, P2 is also going up, but the most prominent peak is negative and not positive. This one uses Roman numbers to label the different peaks. This is the labeling system that is recommended by the Academy of Clinical Neurophysiology. So the answer to this question is false. Next question. Flash evoked potentials produce similar waveforms regardless of methodology. A true, B false. Lamp-generated flash VIP normally consists of 3 principal features. An initial negative peak with a latency of approximately 70 to 80 milliseconds, usually labeled N75. A larger positive component with a latency of approximately 90 to 110 milliseconds, usually labeled P100, and a large negative component with a latency of approximately 130 to 140 milliseconds, labeled N135. The number implies where the peak should fall in normal adults. When goggles are used, the waves look rather different and are usually labeled in a numerical order using Roman numbers. This numerical order corresponds to the order in which the different peaks appear in the normal adult. When Ganzfeld stimulator is used, the waves are most of the time labeled with the letter P for those going up, followed by the number 1, 2, and 3 according to the order they appear in the normal adult. And the letter N is applied to those peaks going down. The N is followed by the number that corresponds to the peak appearance in normal adults. So the answer to this question is B. Next question. The American Academy of Clinical Neurophysiology recommends peaks to be labeled by Roman numbers. A true, B false. This is the terminology suggested by the Academy. As you can see, Roman numbers are used for each of the wave in an orderly fashion. So the answer to this question is A. Next question. The presence of an intact flash VIP demonstrate conscious visual perception. A true, B false. If a patient complains of not being able to see, but that patient has a normal flash VEEP. The presence of the normal flash VEEP cannot be used to diagnose malingering. So the answer to this question is false. Next question. The analysis time for flash VEEP in patients under 1 year of age should be dash milliseconds. A 100, B 250, C 500, D 50. This tracing is an average VEEP from 75 subjects using flash stimulation. The figure above, indicated by the arrow, shows how the study looks when the study is represented at a faster but constant speed. That is when the same time scale is used for the evoked potential and for the rhythmic after discharge. The term rhythmic after discharge is applied to the waves that occurred after 250 milliseconds when the analysis time is allowed to run for 2 seconds. In this extended sample, the scale used for the proper evoked potential, which in this figure is labeled with the terms primary and secondary responses, is different from the scale used after for the rhythmic after discharges. The rhythmic after discharges have no clinical significance. The proper evoked potential in this study was present within the first 240 milliseconds of the stimulus, and this is how it usually happens in adult. So in adult, no clinical relevant information is gained by prolonging the study longer than 250 milliseconds. In infants, the story is quite different. This new frame has 3 VEEP patterns seen in neonates. As you can see, the analysis time is 500 milliseconds. The mature type has a peak level that is N3 shortly after 300 milliseconds. The one labeled typical because it was found in most neonates in the study presented here has N3 way past 300 milliseconds. And in the study labeled immature, P3 occurs at about 400 to 500 milliseconds. So having an analysis time of 500 milliseconds is important in this age group as well as in all infants. So the answer to this question is C. Next question. The most robust components of qualitative flash VEEP are the N2 and dash peaks. A N3, B P3, C P2, D N1. Quantitative flash VEEP are obtained using Ganzfeld stimulator or similar devices. The most robust peaks are N2 and P2. The amplitude of P2 should be measured from the preceding wave, that is from N2, as shown in this frame. The recommendation made by some neurophysiologists and ophthalmologists is to call amplitude statistically abnormal if its value is above 97.5% of controls. The clinical relevance of such abnormality has not been defined. Latency is considered by some to be abnormal if the delay is more than 132 milliseconds. That is, if from the stimulus to the appearance of P100 takes longer than 132 milliseconds, or if the interocular latency discrepancy is more than 6 milliseconds. Yet these values are highly uncertain, and normals should be established in each laboratory, and furthermore, according to the Academy of Clinical Neurophysiology, the only significant abnormality is when the flash evoked potentials are not present on one side. So the answer to this question is C. Next question. Which of the following statements is true with regard to maturation? A. Visual evoked potentials can be present at 25 weeks conceptual age. B. Negative potential are more prominent than positive potentials in preterm neonates. C. Bifid P100 are often seen at term. D. All of the above. This frame has 6 VIPs corresponding to different ages. Notice that the analysis time is 1000 milliseconds. The flash VP of most 25 preterm neonates have a negative peak labeled N300. At about 30 weeks, the first positive peak appears. It appears at about 200 milliseconds. By term, the first positive peak is usually sharper than before, and it is usually at the same time, at about the first month of life, that the peak becomes bifid. The first of these two peaks is close to 100 milliseconds. That is, the latency of this first peak is about 100 milliseconds. As a matter of fact, many authors consider a P100 delay longer than 200 milliseconds a significant abnormality in this age group, especially if the delay persists after 5 weeks of age. It is also during the neonatal period that we start seeing a negative peak at 70 milliseconds. At about 3 months of age, in term babies, no longer we can see the bifid P100. By 9 months, P100 is usually at 100 milliseconds. So the answer to this question is D, all of the above. Next question. When reporting neonatal VIP, the method used to label peaks should be stated. A, true, B, false. I hope you remember this tracing from a recent question. Notice that the peak indicated by the arrow is labeled N3 and not N1, despite being the first noticeable peak. And that the peak indicated by the arrow here is labeled P3 and not P1 or P2. The same goes for this peak now pointed by the arrow. As you can see, it is labeled P2 despite being the first positive peak found. This was so because the author and many other neurophysiologists in the field define P2 as the positive peak that occurs between 126 and 300 milliseconds. N3 is defined as the negative component between 200 and 400 milliseconds. P3 is defined as the positive component after N3, and P1 as any positive component before P2. So the answer to this question is true. Next question. By 4 to 5 years of age, flash VIP P100 reaches adult latencies and configuration. A true, B false. It is true. By 5 years of age, VIP of a child and of a man look exactly the same. That is, of a child and an adult look exactly the same. So the answer to this question is A. Next question. The guidelines from the American Clinical Neurophysiological Society states that the only flash VIP definitely significant abnormality is the absence of a demonstrable response. A true, B false. This is the example of flash VIP presented in the guidelines by the society. It was obtained using goggles and stimulating the left eye. The analysis time was 250 milliseconds. The preferred montage is highlighted. The left ear was used as a reference for all channels. An alternative montage is to use link ears as a reference or the vertex as a reference for all occipital derivations. The guideline states, as I have mentioned before, that the only definitely significant abnormality is the absence of a demonstrable response. The Academy goes on to say that lower amplitude in one side is bad if it is too low. Longer latency on one side is bad if it is too long. And that symmetrical high amplitudes may be bad. So the answer to this question is true. Next question. P100 recorded using lamp flash with a latency of more than 132 milliseconds or an interocular latency difference of more than 6 milliseconds is abnormal. A true, B false. The closer I got to a straight answer about normalcy in flash VIP was in the evoked potential primer. It places the limit of normalcy at 132 milliseconds for latency to P100 and for interocular difference it established 6 milliseconds as the upper limit of normal. But still, the prevailing recommendation throughout all the reading I have done about flash VIP is that each lab should establish their own normal based on age-matched controls studied in the proper lab. So the answer to this question is A. Next question. Flash beep can be used to document recovery after head trauma. A true, B false. The flash VIP that I am showing you and those that I will show you in a few seconds all belong to a patient with occipital head trauma. The VIP that you're actually looking at was a flash VIP that was done soon after the occipital trauma. As you can see, no recordable waves were present in the left eye. 1 month later, the waves were present when the left eye was stimulated, but they were poorly formed, as you can see, and they are clearly present after 2 months. The aqua arrow I have just introduced compares the P100 latency of the right eye soon after trauma at 1 month and at 2 months after the trauma. Notice the position of the vertical yellow line in relation to the arrow. The yellow line indicates the P100. The magenta arrow I have just introduced represents the latency to P100 at 1 month and at 2 months in the right eye, and in the left eye you can see similar decrease in latency in both. The distance between the right and the left P100 is more than 6 milliseconds, which is considered by some abnormal despite the presence of a normal latency to P100. Also notice the amplitude of the P100 at 1 month and at 2 months. It is important to stress that these findings have to be interpreted in the context of the clinical findings, and on their own cannot be taken as an indication that the patient is getting better if the clinical picture speaks to the contrary. So, as the saying goes, VIP, that is flash VIP, may be used to document improvement but not to diagnose it, unless the improvement is coupled with clinical improvement. So the answer to this question is A. Next question. Please look at this frame and answer the question. What is the amplitude of P100? Notice that the time scale is 25 milliseconds per division at the upper tracing and at the lower tracing. The scale for time has to be the same for both. Now notice that the scale for amplitude is 2 microvolts per division in the upper tracing and 1 microvolt per division in the lower tracing, though the amplitude scale may be different in each tracing. In this frame, the amplitude of the smaller wave is calculated. This is not right because we must always choose the wave with the larger amplitude for calculations. In this frame, the measurement is also wrong because the P100 was measured in relation to the following wave and not the preceding wave. This is correct because the amplitude here is being measured from the preceding wave and in the same wave. So the answer to this question is B. Next question. Latency to left P100 is A. 98 milliseconds, B. 110 milliseconds, C. 105 milliseconds, D. 103 milliseconds. The legend indicates 25 milliseconds per division. 4 divisions are present from the stimulus to P100. So the answer to this question is A. Next question. Which of the following wave should be labeled N75? A. Wave A. B. Wave label B. N75 is the negative peak that precedes P100. So the answer to this question is B. Next question. Abolition of VIP during surgery for 2 minutes indicates irreparable damage to the visual pathway. A. True. B. False. The use of VIP during surgery is limited. When used, flash stimulus is preferred since attention, fixation, and having the eyes open is not a necessity. The visual evoked potentials in this frame was obtained during surgery using a stimulator called Aston stimulator. For our purpose, we can consider it as a lamp stimulator. Notice the time legend. As you can see, pointed by the arrow, the surgery was aimed to remove the optic nerve. The first tracing was obtained prior to surgery. The most significant wave, to which we are going to refer to as the main wave, at this time appeared at about 110 to 120 milliseconds. The incision was done, and all the time, even during drilling, the main wave was well maintained. Once retraction started, the size of the main wave dropped. But in a subsequent tracing, several minutes later, you can see that the main wave comes back in pretty good shape. And it stays so. This is so until the optic nerve is severed. At the time the nerve is cut, the main wave disappears. So there is no doubt that the main wave reflected optic nerve conduction. But the most interesting occurrence in this sequence, I think, is that at this point, indicated by the arrow, the wave looked good. At this time, it is almost gone, and here it is good again. I think that this is remarkable because it shows the capacity of the visual pathway to recover. You can read the conclusion of this paper in this frame. Abolition of visual evoked potential does not indicate irreparable optic nerve damage. But the author suggests that if the absence of the major potential is for longer than 4 minutes, a search for remediable causes of optic pathway damage should take place. So the answer to this question is false. Next question. Intraoperative visual evoked potentials have proven to improve surgical outcome. A. True. B. False. Intraoperative visual evoked potential monitoring during surgery that places the optic nerve chiasm and tract at risk makes sense. In this frame, you can see 3 robust peaks present during the pre-surgical VIP. The positive peak just before 100 milliseconds was labeled using the Roman letter 3. The negative peak at about 100 milliseconds was labeled 4. And the positive peak just after P 100 millisecond was labeled 5. Here I have selected the amplitude of the 3 to 4 as the amplitude to follow. I like to stress that choosing a wave to follow during surgery is often a romantic decision. In general, we can say that earlier waves are chosen over later waves. Pre-surgical robust waves are chosen over less robust ones, and those that occurred at about 100 milliseconds from the stimulus, regardless of the polarity, are chosen over those waves that occurred later or earlier. Some neurophysiologists, I think most, consider a drop of 50% in amplitude significant, although I think that most would inform the surgeon of any change in amplitude and morphology occurring at a vulnerable period during the surgery. Latency is also monitored, but it is usually less reliable. In this case, latency was monitored from a stimulus to wave 4. An increase of more than 50 milliseconds is considered by most neurophysiologists as a significant abnormality, significant enough to warrant telling the surgeon, but others consider any increase in latency of more than 10% to be significant. In the next frame, I will show you a recording demonstrating the changes I have just mentioned. The arrow points to the magenta wave, which is the ghost of the normal wave recorded prior to surgery and prior to any problems. Although the arrow was placed pointing to the MOA1 derivation, all other derivations with the same color are also ghost waves. The white wave in this frame being pointed by the aqua arrow is the real time, and as in the prior frame, although the arrow is pointing to one derivation, the same can be said about all 4 derivations. You can see by comparing the magenta wave, that is the ghost wave, with the white wave, the one in real time, that the 3 to 4 amplitude of the real-time wave, here represented in green, has dropped more than 50% from the ghost wave, the amplitude of which is represented in cream color. This is obviously an abnormality. Also notice by comparing the cream color arrow with the aqua arrow that the latency has also increased. Obviously, the surgeon must be notified in the presence of these changes. In general, as you can gather from our discussion, neurophysiologists can approach warning the surgeon during intraoperative monitoring using one of 2 principles. We can either warn the surgeon after a predicted limit, such as 50% drop in amplitude or 10% increase in latency, or we can warn the surgeon after any change in waveform, amplitude, latency, or morphology that exceeds the baseline variability. In general, amplitude changes seem to be more significant than latency or morphology changes. An important point to remember for all type of intraoperative monitoring is that the longer it takes to get an average, that is, the more trials needed to get a meaningful recording, the sooner you want to notify the surgeon of an abnormality. Having said all that about intraoperative VIP, it is important to remember that statistically, with the protocols that are being used at the moment, intraoperative VIP has not shown to make a difference regarding outcome. The hope is that better protocols in the future will change this. So the answer to this question is B. Next question. Filter setting for intraoperative VIP and regular VIP are used at the same settings. A true, B false. Regular VIPs are recorded using low frequency filters set at 1 Hz and high frequency filters set at 100 Hz. Notch filters are not used. OR VIP are recorded using low frequency filters set at 5 Hz and high frequency filter set at 500 Hz. Again, notch filters are to be avoided. So the answer to this question is false. Next question. At a stimulus rate of 1 per second, if you require 50 trials to develop an average, how many averages can you get during a 5-minute period? A2, B6, C8, D25. Given 5 minutes, which is to say 300 seconds, stimulating at 1 trial per second and using 50 trials to get an average, those 50 seconds to get an average, applying the mathematical rule of 3, as you can see in this frame, the answer becomes obvious. The answer is 6 averages. So the answer to this question is 6. B. Next question. Electroretinograms are at times performed in conjunction with pattern VEPs. A true, B false. This frame shows an example of a normal VIP to binocular full field stimulation. The reason I show you this figure is to indicate that in certain centers, electroretinograms are done in conjunction with VIP. So it is important for neurophysiologists to have an idea of what electroretinograms indicate. So the answer to this question is A, true. Next question. Skin electrodes can be used for qualitative electroretinogram. A true, B false. Electroretinograms are usually done one eye at a time. Electroretinograms can be quantitative or qualitative. As you can see, different types of electrodes can be used for recording electroretinograms. Corneal electrodes are used for quantitative studies. They are usually done by ophthalmologists. They require corneal anesthesia and pupillary dilatation. Qualitative studies are, as I previously mentioned, done at some neurophysiology labs. They are usually done using periorbital regular EEG electrodes. The primary electrode is placed in the lower eyelid, reference in the mastoid, and the ground on the forehead. An alternative montage is to place the reference electrode in the corner of the eye, as you can see in this frame. All the other electrodes are placed in the same location. So the answer to this question is B. Next question. Qualitative electroretinograms can be done using flash and pattern stimulations. A true, B false. Quantitative ERGs consist of focal ERG that measure the function integrity of the fovea and is therefore used to provide information for diseases limited to the macula. And a second type of quantitative ERG is called multifocal ERG. Multifocal ERG simultaneously measures local retinal responses from up to 250 locations. These tests are done by ophthalmologists. Qualitative ERGs can be done using flash or pattern stimulus. Flash ERG produce a tracing consisting of a wave labeled A generated by the action of photoreceptors and a wave labeled B generated by multiple retinal cells, including the cell of Muller. The other type of qualitative ERG, that is the pattern ERG, produces a similar waveform. The A wave is produced by photoreceptors and the B wave is produced by the action of multiple retinal cells, as it is for the flash ERG. I find it interesting that in the evoked potential primer, a point is made that ganglion cells contribute to the production of the B wave in pattern ERG. So the answer to this question is A. Next question. Light induces depolarization of cones and rods. A true, B false. When light comes in and hits the pigmented epithelium, the cones and the rods undergo hyperpolarization. It seems that their hyperpolarization is responsible for the A waves in the ERG. So the answer to this question is false. Next question. Visual pathway conduction time is A. 10 to 50 milliseconds, B. 51 to 100 milliseconds, C. 101 to 200 milliseconds, D. over 200 milliseconds. We have already seen this figure before. I am bringing it back to emphasize that the A wave is produced by the reaction of the photoreceptor cells, that is, the cones and the rods. The B wave are generated by multiple cell types in the retina, whose function is not to mere conduct electricity. These cells are involved in processing electrical information. Thus, using ERG, that is the B wave in the ERG, to determine conduction time is bound to be misleading. Be it as it may, we need to measure the electrical activity in the retina, where it starts, and in the primary cortex, where it first arrived, in order to determine central visual pathway conduction. This could be approached in three ways. First, by determining the milliseconds from wave B in the electroretinogram, which usually occurs at about 50 milliseconds after the stimulus, to P100. This graphic illustrates this approach. From wave B at 50 milliseconds to P100, the conduction time would be estimated to be 50 milliseconds. The second approach is to measure directly from the optic nerve to the first VIP peak recorded at the occipital cortex, that is N75. Measured this way, the conduction time would be 35 milliseconds. And the third approach is to measure from the optic nerve action potential to even an earlier potential capture in the occipital lobe at 50 milliseconds. Such an approach will give us a conduction time through the visual pathway of 10 milliseconds. So the answer to this question is A. Thank you very much for your attention.